O professor Neirote aí de Boston acabou de entrar aí na sala. E o Robertinho Carvalho mostrou a cara, continua jovem.
Muito obrigado.
Luquez,
boa noite, tudo bem com vocês? Boa noite.
Boa noite. Michael Mack, how is the vaccine plan in US? Is going well?
How is the what?
The vaccine.
So yes, there's about 50 to 55% of the population has been vaccinated partially, and about 30% overall. The problem now is that it's a political issue, and there's all those people that believe Trump that are refusing to get vaccinated now. So it's the same one that don't want to wear masks, don't want to get vaccinated. So, a much higher percentage could be vaccinated than are. There's more vaccine than people right now waiting to get it. And so now the U.S. is going to export vaccine to India and other places.
Okay, send some for Brazil. We are needing.
Well, I believe that in Brazil, people are accepting vaccination more friendly, but we're in shortage of vaccines.
Okay, Vanderlei, it's now 7 and
Vamos
1
começar.
minute past 7. Can you wait more 3 or 4 minutes, or let's begin?
Bom, gente, boa noite. Oficialmente vamos começar a reunião da nossa academia. E hoje nós temos a honra de receber o professor Michael Mack, uma das lendas da cirurgia cardíaca do mundo, a quem nós damos as boas-vindas, depois vocês traduzam, né? E devido à minha absoluta, como é que se diz, incompetência para falar inglês, nós vamos apresentar o professor Fernando Lucchesi, que todos vocês conhecem, para fazer uma pequena apresentação sobre o professor Michael e depois delegar para que ele e o Enio possam conduzir as discussões. Viu? Então, um abraço a todos e boa reunião. Lucchesi, por favor, liga o microfone. Liga o microfone, Lucchesi.
Dr. Mack, I have the mission of introduce you,
Okay.
which is very difficult because, you have so many things done in life that I could select some at least to show to our friends here in Brazil.
Well, you know what I say about that? All that means is that I'm very, very old now.
Right. Not that much. Well, Dr. Mack earned his medical degree from St. Louis University in 1973. He then became board certified in internal medicine and then followed residency programs in general surgery and cardio surgery. He is the medical director of cardiothoracic surgery for Baylor Scott and White Health and the chairman of BSW, the Heart Hospital Plano Research Center in Dallas, Texas. Mack was president of STS and member of the board of trustees of the American College of Cardiology. Dr. Mack is a gifted surgeon who applies evidence-based medicine to everything he does. In this aspect and many more, he reminds me Dr. John Kirkley, with whom I trained in 75, 76 in Birmingham, Alabama. Dr. Mack is a devoted student of causes of death in cardiac surgery, fighting for lowering mortality of coronary and valve surgery. Here is one of his famous statements. This is really interesting. If the airline industry accepted our 1.9% error rate for coronary surgery, there would be 542 airline crashes, resulting in 64,000 deaths every day in the US. It's fantastic. I like that sentence. That's definite sentence. He was the first surgeon to break the existing wall between cardiac surgery and interventional cardiology. He was outstanding at this point. He served in the steering committee of the Syntax trial, together with Fred Moore and Patrick Sarois. He built a strong and durable bridge between surgeons and interventionists. Mack said that having the opportunity to help forge a relationship between two specialty groups that have not always seen eye to eye is one of his accomplishments of which he is most proud, and he should really be. This connection grew through Mack's participation in the partner trial, which explored the safety and efficacy of TAVI with the SAPIEN device. He started a profitable connection between Dallas and Leipzig due to his close friends with Fred Moore, his close friendship with Fred Moore. A scientific meeting between the two institutions was carried out for years. I attended at least 2 of those. From our side, we can say that Michael Mack is a pioneer in the field of cardiothoracic surgery and a well-renowned physician. He was the founder of the Heart Team, an institution that improved cardiovascular medicine to unpredictable standards. Another of his sentences: a patient's treatment should not be dictated by what specialist's office they walk into first. Forgetting all his contributions in considering just the creation of the Heart Team, cardiovascular surgeons should already be very much indebted to Dr. Michael Mack. Dr. Mack, thank you very much to have accepted the invitation of the Brazilian Academy of Cardiovascular Surgery. The floor is with you.
Well, Fernando, thank you for that very kind and very unique introduction. There are actually some parts of that I had forgotten about, so I appreciate the effort that went into that introduction. It was very flattering, and thank you very much. So let me see if I can share my screen here. All right, can you see my screen okay?
Okay.
All right. So what we discussed, or what I will present on, is the past, the present, and the future of cardiac surgery. As I said at the beginning, I'm old enough to have lived through a lot of different eras of cardiac surgery, and I've seen how the evolution has happened, and I've had a lot of concerns about the future of cardiac surgery. So I've put a lot of thought into this, and what I want to share is where, in my opinion, we have come from, where we are right now, and what is going to be the future of our specialty. So this is my conflict of interest disclosure. I am in the leadership of a number of trials in valvular heart disease. So, the first question is cardiac surgery an endangered specialty? And you say, why do I ask that? Well, if you look at recent events, where I first had this concern raised is when I was debating Patrick Sarois in Vienna in 1999. This was prior to the Syntax trial. And in the debate, he said, CABG surgery will be dead within 10 years. So this said 2 things. One is the acceleration of percutaneous treatment of coronary disease, and also the view of the interventional cardiologist about cardiac surgery. Well, as we have seen since, that certainly hasn't happened. CABG surgery is not dead 22 years after he made that statement, nor is it dying either. If we look at recently what happened, this is the STS database. and look at the treatment of aortic stenosis, yellow is TAVR on the bottom. And you can see that the number of TAVR procedures is now causing a shrinkage in the number of all types of surgical aortic valve replacement. So is the same thing happening in aortic stenosis that happened in coronary disease? So as Shakespeare said in The Tempest, whereof what is past is prologue, I think if we look to the past, it'll help us address the future. So what I want to talk about is where have we been, where are we now, and where are we going? So if we look at the history of cardiac surgery, it actually started as a specialty of thoracic surgery. And I would posit that the history of thoracic surgery is staying one operation ahead of extinction. It always has been a specialty of evolution. So, the first procedures performed in thoracic surgery was bronchoscopy. And the surgeons were replaced from doing bronchoscopy by fiber optic bronchoscopy, which is now done by pulmonologists and critical care specialists. Rheumatic heart disease, I'm sorry, let me go back just a minute. Okay. There was a slide that was missing. I apologize for that. Rheumatic heart disease was the beginning of the era of cardiac surgery with mitral commissurotomy. But that was replaced for the most part, at least in first world countries, with the advent of penicillin curing rheumatic heart disease for a large degree. And in those parts of the world where rheumatic heart disease is still prevalent, balloon mitral valvuloplasty has replaced the initial operations of closed and then open mitral commissurotomy. Similarly, pacemakers started out as a surgical specialty, with the first person receiving a pacemaker for Stokes-Adams attack in 1959 on the left, and the early pacemakers requiring a surgical procedure for implantation on the right, and now being replaced by a tiny pacemaker with a leadless implant in the right ventricular apex that does not require surgery anymore. So again, a procedure that started out as a surgical procedure has evolved to other specialties, has become less invasive. You could arguably say that the specialty of thoracic surgery started with the management of tuberculosis, with all these innovative procedures, including thoracoplasty for the management of patients with tuberculosis. But the role of surgery has become minimal now with the advent of streptomycin. And now other secondary and tertiary antibiotics to control the disease, and it's not nearly as prevalent. So again, thoracic surgery had to move on. This is an implantable defibrillator. The original one in 1980, again, which required a surgical procedure, has now evolved to the size of a pacemaker, no longer requiring a surgical procedure. Arguably, the glory days or the golden era of cardiac surgery happened in the 1960s as the specialty exploded. And the operations that we did were on the cover of the national medias around the world. This is the Life magazine cover of the first heart transplant in 1967 in South Africa. Surgeons were again on the covers of national magazines and international magazines for the great work that they did. This was DeBakey with an artificial heart. And this is William DeVries, again with an artificial heart, on the cover of Time magazine. Even our internursing battles within our specialties. the fights made it to the cover of national magazines, with DeBakey and Cooley, their bitter feud again being featured in the lay press. I would also say, going back to this, that at this time, I was in high school and university, and I gotta have believed that subconsciously somehow this had to play an influence in me going into cardiac surgery as a specialty. And now, we have coronary revascularization. This is more than any single procedure, the operation that created a cardiac surgery, with the explosion that happened in the late 1960s and early 1970s. However, that again, as Professor Sarice alluded to, was being threatened by less invasive procedures. And now we're at the era where surgical aortic valve replacement, one of the operations that we take great pride in, seems to be being replaced by TAVR. And if we look at the universe of a treatment of aortic valve in the United States, you can see the blue line on the top is all aortic valve procedures, with about 70,000 being performed annually. The final numbers aren't in from 2020, but it looks like there were 75,000 TAVR procedures done in the United States. So it looks like the number of TAVR procedures now exceeds all aortic valve procedures. And now we have mitral valve disease, with a number of transcatheter edge-to-edge repair procedures now approaching surgical mitral valve replacement. So again, to emphasize, this shouldn't be, we shouldn't be depressed about this. We shouldn't be sad about this. We shouldn't be bemoaning this fact, because our history has always been staying one operation ahead of extinction. It's the natural evolution in the treatment of a disease to address it the best way you have it at the time, and then find less invasive ways of treating a disease. So the treatment of heart disease constantly continues to change, and you can argue whether this change is for the better or for the worse, but clearly things change over time, and usually for the better. So this is a quote that comes from Professor Moore in his presidential address at EACTS in, I believe, 2016. And this was from a Episcopal priest who said, "Learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow." And I think that that's a trap that we all get caught in, that we have great success and think that things aren't going to change, and that what we did yesterday will be good enough for tomorrow. And it doesn't matter whether you're in medicine or technology or whatever, you constantly have to evolve. So what's the road from here? Where are we going? Well, the first is, let's look at some principles of surgery here. And I think the quote by Einstein is very operative here. Everything should be made as simple as possible, but no simpler. And the trick is figuring out when you've gotten as simple as you can, but you aren't sacrificing something by being simpler. So this is a good friend of mine, and I think a number of you know him, is Vince Gaudiani. And Vince is, I would call him the surgeon's surgeon. There is nobody that is better at doing large, huge cardiac operations than Vince Gaudiani. And I asked him a few years ago to help me write an editorial on the future of cardiac surgery. And he sent me a very long email about some of his thoughts. And I'm sharing some quotes from this email about a person that I very much consider to be a master surgeon, about his thoughts on the future of our specialty. And that is, if you have to be a master surgeon to perform an operation, then the operation is not widely adoptable or of significant value. So, think of it as a complex mitral valve repair for Barlow syndrome. That is not something that can be done well by most cardiac surgeons. You look at the David procedure for aortic regurgitation. Again, that's a procedure that's performed mostly by experts and not by the majority of cardiac surgeons out there. And that's one of the reasons that interventional cardiology has been so successful, is they've developed procedures mainly due to devices that make the procedure, you don't have to be a master operator in order to perform most interventional cardiology procedures. So he talks about what he calls big case surgery. And some examples are Whipple procedures for pancreatic cancer, radical mastectomy, open abdominal aortic aneurysms, esophagectomy, and circulatory arrest aortic arch procedures. And he says the decline of big case surgery began before we started training. It was always the product of an age which it developed, and that age has passed, and it will decline. Big case surgery includes operations that depend heavily on the technique of the operator. They are complex, life-endangering, and most important, the physiologic consequences of the procedure are major, independent of the success of the operation or skill of the operator. These operations are a consequence of a particular moment in the history of science. The device part of this revolution reduced the necessity for technique by building more of the solution into the technology. Technique would remain important, but far less so than it was with surgical solutions. Therefore, outcomes are more dependent on the device than they are on the technical ability of the operator. And again, I think we can think of multiple examples in which this holds true. I always remember this quote from Denton Cooley very, very well. The worst thing that happened to me was the invention of the heart-lung machine, because then any pedestrian surgeon could do heart surgery. In other words, the very technology that allowed heart surgery to expand to the masses around the world, Denton Cooley bemoaned, because you didn't have to be a master operator to be able to do these operations. The heart-lung machine and subsequent ischemic cardiac arrest leveled the playing field, if you will, so that the expertise required by the surgeon didn't need to be as great. So, I have had the opportunity of publishing a lot of articles over the years, and this is probably the one that I have put the most thought into. That this comes from the Millennium issue of JAMA in 2001, and I was asked to write the next millennium of surgery, and with a focus on minimally invasive and robotic surgery. I actually wasn't the one that was invited to write this. Originally, it was Robert Guyton. And he said he didn't have enough knowledge to do it, and suggested me. Well, I didn't have enough knowledge to do it either, but that didn't stop me. And I reached out to every surgical specialty that I could think of and asked what the future of their specialty was. So I reached out to orthopedic surgeons, general surgeons, ophthalmologic surgeons, 12 different specialties. And there were 4 common themes that came through over and over again. And that was that the future of surgery would be ablation over excision. So in other words, we wouldn't be cutting out tumors in the future. We would be ablating them. And I think we've seen this come true. Remember, this was written in the year 2000 and published in 2001. Image guided over direct vision. Reconstruction without suturing. And lastly, access via natural orifice or blood vessel over incision. Now, remember, back at that time, nobody had ever heard of TAVR. There were a few people that thought about it, but I had never heard about it. And if you look at a TAVR procedure, it incorporates 3 or 4 of those principles: image guided over direct vision, reconstruction without suturing, and access via blood vessel over an incision. And if I think back at that time, how many times have you seen an idea and you say, why didn't I think of that? TAVR, I make no apologies to myself for not having invented TAVR. I knew, I was thinking as a surgeon, and I knew all the reasons why this couldn't work, all the reasons why this couldn't go wrong. Well, you've got to cut out the old valve. Well, no, you don't. Well, you got to be able to see what you're doing. Well, no, you don't. Well, all that calcium is going to go to the brain. Well, yeah, it kind of does, but it doesn't cause the clinical problems that you used to. And how are you going to hold that valve in place without stitches? So again, I wasn't thinking enough out of the box that I make no apologies to myself for not having been the person that invented TAVR. But what I did do was I recognized early on that this was going to largely replace surgical aortic valve replacement. I saw my first TAVR procedure in 2001 in a laboratory at Edwards Life Sciences. And I immediately appreciated how this is going to work. And I had suffered through all the surgery, interventional cardiology wars of coronary revascularization. And I said, I have a choice here. I can deny that this is going to happen. I can put my head in the sand and pretend it's not going to happen, or I can get involved with it and keep surgeons in the game. And that's what I elected to do in the early days of TAVR. So another principle is, like in American baseball, a tie goes to the runner. And what do I mean by that? If you have 2 options and the outcomes are basically the same, then the less invasive procedure beats the more invasive procedure every time. It will be preferred by patients, and it will be preferred by referring physicians. So if you look at TAVR versus SAVR, if a less invasive procedure is non-inferior to a more invasive conventional procedure, then it's going to be superior in the minds of patients and their referring physicians. So all TAVR had to do was tie SAVR, and TAVR is going to replace SAVR. Same thing if you look at coronary revascularization. We know that in long term, the best thing that you can do is bilateral internal mammary arteries for 20-year survival. But nobody looks at 20-year survival. They look at short-term survival. And the survival for most patients is the same with PCI than with CABG. The less invasive procedure is preferred. So how do we take all this and move forward? I think to survive and thrive in cardiac surgery, we need to focus on subspecialization. I don't think we can continue to do all procedures as a what I call a generalist cardiac surgeon and do them well. I think we have to focus on specific procedures, such as aortic valve specialists, mitral valve specialists, thoracic aortic specialists, heart failure specialists, structural heart disease specialists, adult congenital. There's now more adult congenital patients in the United States undergoing surgery than there are congenital patients. So that is and should be a specialty unto itself. What I skipped here was coronary artery disease. And I think that that's a mistake we made in our specialty. We treated this as a generalist procedure that everybody does. And I think we should have had the same coronary specialists as we do valvular heart disease specialists and heart failure specialists. You know, there are a few surgeons like Dr. Salerno and Dr. Puskas and Dr. Taggart, for example, that specialized specifically in coronary surgery. But the most part, we haven't, and we should have created a specific subspecialty of coronary surgery. So let me just focus on these 4 areas: coronary revascularization, valvular heart disease, thoracic aortic disease, and advanced failure. First, coronary revascularization. Despite the fact that 3 out of every 4 procedures performed for coronary revascularization is PCI, done by a catheter, coronary bypass surgery is still the most common operation a cardiac surgery performs. There are 55% of all procedures that we do are coronary bypass surgery. And that's where our main focus should continue to be, is how we make bypass surgery better. So in 2019, there were 300,000 cardiac operations done in the United States, and over 160,000 of those were CABG procedures. Now, we have known for at least 10 years and longer that the best long-term survival is with all arterial grafting. Yet, only 8% of patients in the United States receive bilateral internal mammary arteries, and only 5% received all arterial grafts. So despite the data, this has not been widely adopted. So this is a technology that I'm specifically enthused about. That's a nitinol mesh that's external support for saphenous vein grafts that goes on the outside, and a trial has just been completed, the VEST trial, and it will be reported at the American Heart Association meetings in November later this year. A randomized trial in which a patient serves as their own control. So in other words, every patient had at least 2 saphenous vein grafts, and 1 saphenous vein graft randomly got this external support and the other did not. And everybody has angiographic follow-up. What the early data on this device has shown that, in effect, this turns a vein into an artery by providing external support and preventing intimal hyperplasia. If we can accomplish by a vein graft the same thing as with an artery, all of a sudden, I think we have a much better procedure long-term and a much better viable alternative to stenting for PCI. Because very frequently we hear our cardiology colleagues say, well, if you're just going to put a vein graft on that, I can put a stent in and do just as well. So I'm very optimistic on this trial. The next is hybrid coronary revascularization. The best thing we do in cardiac surgery is a lima to the LAD. I always thought that a hybrid coronary revascularization in which you put a lima to the LAD through a small incision and then stents to the rest of the vessels had the best of both specialties working together. Well, it's never really gained traction. There are 2 or 3 different times that it looked like it was going to be more widely adopted. Yet there are pockets of centers in the United States that are using this broadly. We do about 50 of these procedures a year. And I think there is reason for optimism that a Lima to the LAD plus stents still has a future. Valvular heart disease. I think despite the success of TAVR, and as we're seeing more and more with MitraClip, there are a number of procedures that are going to stay with cardiac surgery for sure. Infective endocarditis is an epidemic of its own in the United States, mainly due to intravenous drug abuse. And the number of infectious endocarditis procedures continues to rapidly increase every year. Another interesting technology is the treatment of ischemic MR. About a quarter of the patients undergoing bypass surgery have ischemic mitral regurgitation. And we showed in our trials that the morbidity of the procedure when you open the atrium to do a repair or replacement is significant. Well, this is a device that you put on at the time of bypass surgery that does an external annuloplasty to the mitral valve and is promising to correct mitral regurgitation without having to open the atrium. I think another area that we're going to see more and more is surgical explantation of TAVI devices. This will be epidemic in the future now that TAVI is being performed in younger and younger patients, and the life expectancy of the patient will exceed the durability of the valve. And as we are experiencing more and more, the complexity of the procedure of explanting a TAVI valve is much more complex than an initial valve operation or even a previous surgical valve operation, especially with the self-expanding valves that get incorporated in the wall of the aorta. And a significant number of these patients require aortic root replacement and a Bentall procedure with significant problems in terms of mobilizing and implanting the coronary arteries. So we are going to be seeing more and more of these procedures in the future with higher degrees of complexity that are still going to require master surgeons to be able to do it. And this is just a graph from a paper that was in the Annals of Thoracic Surgery from the University of Michigan that shows their number of TAVR explant valve operations continues to increase. I think another disease that we're seeing more and more is mitral annular calcification. And I don't know about you, but this is the disease that I had dreaded most treating over all the years, just because of the risk of both mitral annular disruption and calcium embolization. Well, there are a number of new options for treating this disease now. Sorry here. So this is a robotic procedure that we're performing by excising the anterior leaflet of the mitral valve and then performing a septal myomectomy to be able to open up the left ventricular outflow tract so there's not obstruction by implantation of a valve. And then what we do after that as an open procedure is sew a layer of felt in here to prevent any paravalvular leaks around it. And once we have this felt strip in place, then we place a TAVI valve inside of of the aortic, of the mitral annulus here. So here you can see a TAVI valve being expanded under direct vision, again done robotically here. And although this can be done by a transseptal approach, a lot of patients aren't a candidate for this because of the hazard of left ventricular outflow tract obstruction. And this provides a great alternative in those types of patients. So this is a very common procedure that were performed. There you see the TAVI valve in place in this patient with mitral annular calcification. Thoracic aortic disease is evolving rapidly, and I think most descending thoracic disease is now treated by endovascular approaches, and now we're seeing ascending aortic disease treated that way. And there are a number of trials going on in the United States now for selected patients, as well as in Brazil, I'm aware, of patients for endovascular treatment of type A aortic dissections. We're also seeing hybrid procedures being performed here, with the elephant trunk procedures being performed by an open procedure, but then allowing a landing zone for further treatment by an endovascular approach subsequently, and now with side branches for aortic vessels. And now we're also seeing aortic arch T-bar being performed, with debranching procedures performed ahead of time to provide revascularization to the great vessels, followed by an endovascular approach. And now we're beginning to see reports of endobental procedures. So a stent to the ascending aorta, and then through that stent, place a self-expanding valve across the aortic valve, so that a bental procedure now can be performed by a totally endovascular approach. And then I think there is a very bright future to treatment of advanced heart failure. In the United States, the number of heart transplants after years of not increasing is dramatically increasing again. And we can talk about the reasons for that, but it is increasing, as well as the number of left ventricular assist devices almost approaches that of cardiac transplantation. And there's a number of short and long-term assist devices available now, with the HeartMate 3 device being the most common. If we look at the INTERMAX registry, we see that the overall post-implant survival now exceeds 93% at 1 year. And this is the HeartMate 3 device. And we see the outcomes of the HeartMate 3 device with 2-year survival of 83%, compared to heart transplant 2-year survival of 82%. Markedly better than the previous earlier versions of the trials of mechanical circulatory support. And there's even been discussions over the last year or two about performing a randomized trial in the US of transplant versus a HeartMate 3 device. I'm not sure we're quite ready for that, but the argument has been the survival at 2 years is the same. It's getting time that we do a randomized trial. This is a device that I'm particularly excited about, which is the Carmat Total Artificial Heart. This was invented by Alain Carpentier, who is still actively involved in the development of the device in the company, now in his mid-80s. This is the idea of the device. That there is a liquid-filled sac here and a rotary pump that alternately pumps blood out of each chamber of the heart. This is lined with pericardial membrane. It's biologic valve, so that anticoagulation will not be necessary. It's a pretty simple implant procedure. You excise the previous heart just like you would on a heart transplant. You sew these cuffs on as well as this clip-on device, and then you clip the artificial heart onto it, and then it's connected to an external controller on the outside. So this has undergone 18 transplants in Europe and Kazakhstan. The 6-month survival is now 73%, and it will start trials in the United States this month in early feasibility studies. The other area that's dramatically increasing is the use of ECMO. And this was increasing even before COVID, for both respiratory flu as well as for failure to wean from bypass situations. But with the COVID epidemic, it is very widely used. And so this is the number of centers in the United States that perform ECMO procedures. There's over 200 centers right now performing ECMO. And this is our experience with COVID in the ECMO registry, with an overall hospital survival of over 50% at the current time. So this is a graphic of COVID patients on ECMO. In the early days of ECMO, we didn't think that ECMO was going to contribute to survival. But we now see that over 50% of patients on ECMO with COVID now survive and are discharged from the hospital. And the average number of days of support is now 30 days. These patients are on it. And we actually mobilize patients and have them walking in the ICU on ECMO so that they can get rehabilitated and gain strength and be able to wean off of ECMO. Now, as Fernando mentioned in the beginning, one of the areas that I got involved with is the heart team, and this was due to the Syntax trial. And I do think that this is very important going forward. Whereas we were adversarial with interventional cardiology, it didn't always work out so well from that standpoint. And there is this quote from the biography of Steve Jobs, who founded Apple, when he had his cancer, abdominal cancer, and was being treated at Stanford. And this is an interesting view of an outsider's way that medicine is practiced. I realized I was facing the type of problem with my oncology care that I never permitted at Apple. My treatment was fragmented rather than integrated. Nobody seemed to be in charge of figuring out how nutrition was related to pain care and to cancer treatment. I was being treated by all these different ologists, but not being treated in a coordinated or cohesive way. So he convened the team of various Stanford specialists at his house to coordinate treatment. Now, I don't think there's many other people that could have convened a group of specialists at his house, but I'll bet you every one of those specialists came to his invitation. But I think this is an interesting anecdote about how somebody who is not in healthcare views the way that healthcare is delivered. And, we do have multiple examples in medicine of multidisciplinary teams that do work well. It has been the bedrock of transplantation over the years. And Fernando mentioned this in the introduction, but rather than practicing in silos, a patient's treatment shouldn't be determined by what door of the hospital they walk into, whether they walk into an interventional cardiologist's office and get PCI, or a general cardiologist and get medical therapy, or a surgeon's office and get CABG, whether they get TAVR or SAVR, whether they get a hybrid procedure, a mitral valve repair from a surgeon who's an expert in it, or replacement from a surgeon that's not, or a mitral clip from a cardiologist. We shouldn't be practicing medicine that way, but so much of a patient's treatment is determined by who sees the patient first. So we have adopted a multidisciplinary clinic in which all care providers and patients get together at the same time. Now, this isn't for all patients, but it's for complex patients. And this is our heart team of surgeons, cardiologists, and imaging specialists. And this is how we practice clinic. This is our mitral and tricuspid valve clinic, in which we have multi-specialists together, all figuring out the right answer. So we started out with our aortic valve clinic during the early days of TAVR, expanded it to mitral and tricuspid valve. We now have a multi-specialty thoracic aortic clinic, coronary artery disease now we're seeing together, heart failure, advanced mechanical circulatory support, and now working with our EP colleagues in the treatment of complex arrhythmias, be it both atrial fibrillation as well as ventricular tachycardia. So the future of the heart team sometimes is all political. It depends who's on top, whether it's the cardiologist on top and the surgeon on the bottom, or the surgeon on top or the cardiologist on the bottom. But it shouldn't be that way. I think there are and always have been a lot of threats to keeping the heart team together. I think it's more important now than it ever has been. Everybody thinks that they constantly think that they don't need each other, but I think it is in our best interest to continue to collaborate. So how does all this add up? Well, if I look back on when I was a resident or an intern in internal medicine in 1973 at the University of Minnesota, so what's that, 48 years ago? This was acute MIs stayed in the hospital a month because there was no way to treat them other than bed rest. Surgical hip operations took 6 weeks to recovery. There was no such thing as a knee replacement. Acute leukemia was universally fatal. Gallbladder disease was an open procedure that took 6 weeks to return to work. Heart transplants had gone from headlines and were abandoned everywhere except at Stanford. And there was no specialty of interventional cardiology. And heart valve surgery was rare. And I looked like this. Now, if we fast forward 48 years, the mortality from heart disease overall has declined by 50% from 1973. Total hip replacements are routine. Bilateral knee replacements are an outpatient procedure. Most leukemia is now cured. Gallbladder surgery is an outpatient procedure. Heart transplants and VADs are now routine. And percutaneous heart valves can go home the same day. And I got a haircut. So we have a very strong heritage in cardiac surgery. And these are the pioneers of our specialty in the earliest days of surgery. We have a heritage that we can be very proud of. Professor Kirkland was mentioned. Here's Dr. Lillehei, Christian Barnard. And I'll close with the final word is there's nothing more difficult to manage, more dubious a success than to initiate a new order of things. The innovator has enemies in all those who profit from the old order, and only lukewarm defenders in all those who would profit from the new order. So this quote comes from none other than Machiavelli in The Prince. And I think it is very, very true. And we can't stop innovating, and we can't continue to believe that success we had yesterday is going to work for tomorrow. However, as Mark Twain has said, I think we can say in cardiac surgery, the rumors of our death have been greatly exaggerated. So thank you very much for the opportunity of giving this lecture. I'm greatly saddened that I have to do it virtually and cannot be with all of my friends in Brazil. Hopefully this pandemic will end sometime in the foreseeable future and that we will all be able to see each other again in person. So thank you again for the opportunity, and I would welcome any comments or different points of view here.
Okay. Paulo.
Michael,
Fernando.
fantastic talk, outstanding talk. In fact, I mentioned Dr. Kirkland in the beginning because I always have the feeling when I've seen you lecturing, I always remember Kirkland. And, it's something like, the transposition of the ideas of Kirkland of science between science and cardiovascular surgery. But more than that, the way you use your thoughts, the way you travel over research in cardiac surgery is absolutely fantastic. I tell you that it's fantastic. I'm your fan. No question about it.
Thank you very much.
So let me give you one brief story, Fernando. So I met Dr. Kirkland once, and that's when I was a chief resident in cardiac surgery, and he was our visiting professor. And I had to host him and pick him up from the airport and drive him around. I was as nervous as can be, found it very difficult to talk to him because he was very intimidating. And my car, it was in the summer in Dallas, and, over 38 degrees Celsius heat, and I had no air conditioning in my car. And he was drenched in sweat the whole time, and he was so upset at me that I didn't have air conditioning in my car. That's the only time I met Professor Kirkland.
Fantastic. I have a question to you, Michael. Should we start to train our young residents in a sort of hybrid way, catheters and open hearts all together? What do you think? What are your thoughts about the training of new surgeons today?
So I think absolutely we have to. So I am a member of the American Board of Thoracic Surgery, and we have just revised the training requirements in the United States that will go into effect next year. And it already requires some experience in TAVR, but it's going to require more experience and in both TAVR as well as endovascular aortic disease, as well as mitral and tricuspid valve transcatheter therapy. I don't think that we can get enough experience during our surgery training, but I think we should be exposed to it and develop some level of ability in it. And then I think that we should have some of our young individuals spend a year just doing structural heart disease. So in transcatheter therapy, I think you need to spend a dedicated year in order to gain any appreciable skill set. And I do think we do need to be involved with cardiac surgery. Otherwise, we will surrender it all to cardiology. So we have 2 structural fellowships a year, 1 surgery and 1 cardiologist. And we have now fully trained 6 cardiac surgeons now over the last 6 years in structural heart disease. And I'll tell you, training the surgeon and the cardiologist together has been the best thing we ever did. They become best friends and they become close colleagues after they finish training.
Very interesting. Well, it's open for the questions. Todos podem fazer perguntas agora, Dr. Mack. Se querem fazer em português, eu traduzo, não tem problema. Enio.
Lucas, depois de ele, eu queria falar.
Perfeito.
Ok.
Dr. Mack, it was an outstanding presentation. The Academy thank you very much for this presentation that make we dream many nights thinking in these concepts that you gave us. You have a lot of friends in this audience, and we admire you for the friendship and for the concepts that certainly will make all of us to think a lot. Thank you very much, my friend.
Oh, my pleasure, Ennio, and thank you for those kind words. And I miss the times that we spent together, and hopefully we'll have the opportunity to again, because I very much value your friendship.
I want to make a...
Eu acho que o Ricardo pediu antes a palavra. Ricardo, por favor.
Okay. Hi, Mike. Ricardo Lima speaking.
Hey, Ricardo. How are you?
I'm fine. And you?
Just fine, thanks.
Good. I'd like to congratulate you for the wonderful lecture, which is always common. My question is about cabbage with an adult pump, and it also involved the concept of a heart team. In the late of 1980s of 2000, this topic was much discussed. And nowadays, there are still surgeons who operate in cabbage only with a pump. And only surgeon dies without pump. So we were unable to get surgeons to accepting being complementary technique of pump and on pump. So do you think one of the difficult of our specialties is to be inside of ourselves? Do cardiac surgeons compete among themselves? What's your opinion about that?
So, I must say that one of my biggest disappointments is that off-pump surgery was not more widely adopted. I think that as Ennio knows, and Ricardo, and Thomas knows, I was a very strong advocate of off-pump surgery, but it was not widely adopted for a number of reasons. One is the evidence of benefit was not compelling. Number two, even though a number of us felt very strongly believed in it, we were never able to demonstrate it in large randomized trials. And the trials that were done by inexperienced surgeons, such as the VA hospitals in the United States, and actually had worse outcomes. Second, we took an operation that I still think is the most complex operation performed in the world in any specialty, coronary bypass surgery. It's much more technically demanding than any other cardiac operation that we did. And we required surgeons to get out of their comfort zone and take a perfectly still bloodless field and sew coronary arteries, and created a moving bloody field to do it. And without strong evidence of benefit, surgeons weren't willing to adopt it. I think it's the same thing with multiple arterial grafting. We're asking surgeons to do a more complex procedure with bilateral internal mammary arteries and radial arteries, and do it off pump when the evidence isn't all that compelling. So we're asking them to get out of their comfort zone. I think that if we had focused on just coronary revascularization specialists that a surgeon feels proud that they are a coronary specialist, just like a mitral valve specialist does, just like an aortic valve specialist does, and focus this on experts, then we could have advanced a number of these techniques, including off-pump surgery, and made them ultimately more widely adaptable. So it is disappointment to me. I know that if I require bypass surgery, I'd want it done off pump, but I'd want it done off pump, not by any surgeon, but a surgeon that's extremely experienced in it.
Well,
Very good.
I'm sorry to be repetitive.
Thank you.
May I make a comment?
Yes,
Fernando?
please, lady.
Well, sorry to be repetitive, Michael, but your lecture was one of the best one I have ever seen. Congratulations.
Oh, thank
I
you.
want to make you a particular question. I'm sorry if it's so very repetitive. I operated on a patient and I made a David operation.
Uh-huh.
And I do the David 5 operation, put in the stitch, pledged stitch. And this particular patient I had 1.5 years later, the patient had probably endocarditis and had aortic insufficiency. And I tried to convince the people of the cath lab to do a TAVI in the patient, but I could not convince them to do the TAVI. And so I reoperated the patient. The patient has done well, but I have to make a Bental with all the difficulty. The patient has done well and is still well. If a patient with a David operation, if the stitches were put with pledged, would you recommend the TAV in this particular patient?
So, I think that that's a very difficult patient for TAVI right now, because there are not good TAVI valves in patients without aortic stenosis and without specifically calcific aortic stenosis. Yeah. Now, in high risk and desperate patients, the self-expanding valve has been used, but with terrible results. There is a valve that's in trial at the current time called the Jena valve. We have experience with it in just 2 patients, but the valve clasps onto the leaflets, and it's specifically designed for patients with aortic regurgitation. So it's still in trials at the current time. There's very limited use. I think it is commercially available in Europe, but that's the only realistic option other than a repeat operation for patients with a failed David procedure.
Thank you very much.
Fernando, eu queria falar.
Sim. Agora o Dr. Paulo Brofman, por favor.
Dr. Mack, it's Paulo Brofman, and I want to thank you for your great lecture. You demonstrate how is beautiful and innovation is our specialty. But I have a question for you. Do you believe that the cardiac surgery and the interventional cardiologist will be the same physician in the future?
So, Paulo, that's a very interesting question. And at one point, probably 10 years ago, I thought the answer to that was yes. But that was probably very naive, in that, just like I said regarding cardiac surgery, that I don't think every surgeon can do every procedure that we do in cardiac surgery and do it well. I don't think that the same specialist can be expert in interventional cardiology and cardiac surgery also. And I'll use a couple of examples. So there are a number of surgeons that have been trained in both. The first one that I remember is Matt Williams, who trained at Columbia in New York, and he's now the chief of cardiology and cardiac surgery at NYU, at New York University in New York. And I thought that he would be the first one of a large area of specialty. And, you know, during his training, he would do a surgical aortic valve replacement, and he'd also take STEMI call and treat acute MIs in the middle of the night. Well, I think that the same specialist could be as good at putting a stent in a STEMI in the middle of the night and then do a David procedure the next day, I don't think is realistic. So I thought 10 years ago that we would train the specialties would come together and a surgeon could be able to do both. But I think I was probably wrong about that, and that's not sorting out. What I do think is that in specific areas, such as structural heart disease, that you can be a surgeon and be just as good at TAVI as you can in other aortic valve surgery. But I don't think you can be doing coronary revascularization and mechanical circulatory support. In a like manner, I think you can be an advanced heart failure specialist and do heart transplants, do durable mechanical support with HeartMate 3s, and put in Impella devices and other percutaneous treatments for heart failure. But so I think on a limited basis you can, but I don't think the two specialties are totally going to merge like I naively thought 10 years ago.
Okay. Thank you.
Very interesting. Dr. Barbosa? Gilberto Barbosa. Ligue o seu microfone, por favor, Gilberto. Ligue o seu microfone, Gilberto. Liga o microfone. Está me ouvindo, Gilberto? Liga o microfone. É isso.
Agora eu estou te ouvindo. Está me ouvindo?
Estou ouvindo.
Ok, obrigado. Professor Michael, I appreciate the didactic and competent way in which you presented your vision on the future of the cardiovascular surgery. My question is, should training in simulators to be mandatory in all residencies program?
So I think that what has happened with simulators is simulators work well for image-based procedures. And so for either fluoroscopy or ultrasound, echo guided procedures, simulators work very great for that. Where they also work well is process simulation, so process of care. So use in cardiac arrest situations or code situations. Process simulation works very well. Where they haven't worked well is nobody's been able to develop a high fidelity simulator to practice open cardiac surgery on, despite a number of attempts at that. Now, I would call the attention to Paul Sargent, who developed low fidelity simulators and trained a couple thousand surgeons in simulation for coronary bypass, and trained some excellent surgeons with low fidelity simulators that way. And indeed, I think his son now has taken over running that school, and it is still active. But with the exception of that, I don't think for most surgical procedures, simulation has turned out to be very practical or applicable.
Thank you.
Mais perguntas? Enio, please.
Please, Mike, I have a question for you. don't you think that we need a study comparing TAVI versus mechanical aortic valves in young people?
So another great question. And, you know, there are a couple, I got a couple of responses to it. I don't know what the use of mechanical valves is in Brazil, but in the United States, it continues to decline. Only 8% of aortic valves are mechanical valves, and those are all virtually in patients under 50. I would say that the advent of TAVI has only accelerated the decline in mechanical valve use, because even though we know that structural valve deterioration happens sooner, the younger that you are, you know, patients in their 50s, nobody wants to take anticoagulation. And they would just as soon take a biologic valve, knowing that it may fail in 8 to 10 years, and then get a TAVI valve in valve and hopefully get another 5 to 6 years out of that, rather than a mechanical valve and anticoagulation. So I am concerned that we will, that's a trial that is not feasible to get done and get enrolled, you know, unless you're talking about patients that are, you know, definitely under 50 and maybe under 40. And then I've got real concerns about putting, you know, a TAVI valve or even a biological valve in patients that young. So yes, I think it's a question that needs to be answered, but I'm not sure that trial can get done. So the other thing that's a shame is that none of the non-vitamin K antagonists, so that the NOACs, you know, are used in mechanical valves. And I think that's a shame. And I was involved in the first trial of dabigatran in mechanical valves, and the compared to warfarin. And the trial got stopped early by the DSMB with an excess of both bleeding and thrombotic events in the NOAC arm of the trial. And since then, nobody has been willing to try it again. I think that it's unfortunate because there were no bleeding events nor thrombotic events in the Coumadin group, in the warfarin group in that trial, which I think was totally serendipity. I mean, because we know so many complications of warfarin. But I think it hurt that whole field in that warfarin alternatives have never been tried again. And I think if they had, then there would be better long-term outcomes with mechanical valves, but I don't think we're ever going to get there. So I think it's an important question, but I don't think it's going to be possible to do that trial.
Thank you, Michael. I would like to hear the comments of Thomas Salerno. Please, Thomas.
Michael, this is one of the most fabulous lectures I ever heard. Obviously, you've been teaching the whole world. Your reputation is impeccable. I certainly appreciate very much all your teaching over the years. As you were speaking, I was trying to figure out one sentence to summarize your lecture, and I found it. And my colleagues already know about this because I keep saying this. Who should have been at the end of that catheter? We did not have a vision. I mean, we lived through this. I remember sitting in Brunswick presentation in Vancouver. No cardiac surgeon believed this will ever be successful. You remember Cribier when he did his first valve. It's because we see them and we don't think it's possible. It's a lack of vision. When you think about the first, second, and third generation of devices right now, you can imagine 5, 10 years from now what this is going to become. Obviously, Another example, Parodi and I, when he was at the University of Miami, discussed stenting for acute type A dissection. He had the vision.
Mhm.
I was operating with him in type A dissection. I could not see how this could have been done. I think the message is very clear, and I wrote this, you may look it up in CTS, in my opinion, that cardiac surgeons should have left the operating room and should have been involved in all percutaneous technology and procedures. You know, we have a lot of friends in Brazil. I'm a great admirer of you for everything you've done. I shared some great moments with you in the past. I'm very grateful that you came to our association today, and many thanks for everything you do on our behalf.
So Thomas, one is I greatly value our friendship and the time we spent together over the years. Second, I agree totally with your statement. And I have said this many times. One of my biggest regrets is that I didn't yell loud enough. I didn't deliver that message. I said it, but I didn't say it enough. I didn't say it loud enough, and I didn't say it frequently enough, because I feel some responsibility that I didn't push us harder as a specialty to adopt transcatheter and percutaneous techniques. And if I had to do it all over again, I would yell a lot louder than I did.
Fantastic. Well, it's nice to have seen and to have heard what Mike said at this moment. It's fantastic, Mike. Mike, I have a conceptual question. We are getting to the end of our session. You are by far the heart surgeon, the American surgeon, more invited to Europe, to trials, to meetings, and your relationship with cardiology and surgery from Europe is very tight. Please make us a comment about innovation, research in Europe comparing with US. I'm very much curious to know about that.
So it's interesting. That is something that has changed a lot over the years. It used to be that most innovation was done outside of the United States. It was done initially in Europe. And then it was done a lot in South America. And the reason being is the regulatory environment in the United States was so rigid and so strict. And what happened was, in order to develop new devices, the human experience all had to be done in Europe, because we couldn't do them in the United States. Well, the devices were largely owned by American companies and financed a lot by American investors. And so there were a lot of complaints made to the FDA in the United States, to the US FDA, and they actually have relaxed the regulations and allowed first in human and early stage procedures to be done in the United States. Now, while this was happening, the regulations in Europe became much more strict, more like the United States. And while this was happening, a lot of the innovation went to South America, including, Brazil, Argentina, Peru, Venezuela. And there still are some first in humans done there, but largely it's shifted to the United States now. So virtually every device is now coming to the United States first, and 10 to 20 years ago, it was all done outside the United States. And, the benefit is that the companies don't have to fly engineers and scientists all around the world for procedures. And the language barriers are not present like they were previously. Now, having said that, COVID has slowed down all innovation in the United States. None of our trials have been enrolling for the last year because we couldn't get patients to come into the hospital. We couldn't allow outside visitors, be it other physicians or be it company representatives into the hospital. So, the innovation has slowed in the United States for the last year, but it's ramping up again. So I was just at a meeting over the weekend virtually that included 40 European surgeons, cardiologists, and imagers, and included the FDA in the United States. And all the Europeans asked, is there a way we can participate in the trials that are going on in the United States right now? So there has been a major shift from Europe to the United States over the last 10 to 15 years, all due to a change in the regulation of medical devices.
Fantastic.
Fernando, Neirotti está presente aí, ele pode falar alguma coisa?
Neirotti, do you want to say something, to give any comments? If yes, please turn on your microphone. You have to turn on your microphone, Rodolfo.
Liga o microfone, Neirotti. Liga o microfone, Neirotti. Neirotti, liga o microfone.
Ô, Ricardinho, tenha paciência com os idosos.
Tá ligado. Although this lecture was mainly based on adult cardiac surgery and very little about what has been my specialty and my passion, that is the pediatric cardiac surgery. And I enjoy it because Dr. Mack has made a very nice revision of the different changes and possibility of new technique. But and then I think we have witnessed in the last several years, it's sort of a battle between the companies that are investing money and backing different new procedures, and that also should be welcome. So that is another thing that I enjoy of this presentation. But then the issue between the surgeon and the interventional cardiologist is something that has been also disturbed me for many years. And the reason for that is that in my profession and in my experience, everything I have done in my life has been discussed with the cardiologist. Everything. I mean, and that was the case because I enjoy that, and because the benefit of that discussion was for the patient and for us learning about cardiology. That was very useful in my experience. Then, but what I have not seen with pleasure that was the issue that nowadays there is no such a discussion in which the cardiologist, the patient are not discussed it sometimes, and the cardiologist see the patient, they study the patient, they make a diagnosis and decide what the procedure has to be done. And that's probably not beneficial for the patient. That is something that I have not enjoyed. And finally, the issue that we have seen that money has also got involved in this, and there have been many cases of people that have been, their decision has been made based on the revenue that they will get from the company, sometimes directly or sometimes indirectly through a trip and payment for congresses and things like that. So that is the part of the practicing cardiac surgery at the moment is a bit disturbed me, and I would like to see some
Obrigado, Rodolfo. Vamos ver os comentários do Dr. Any comments, Michael?
Yeah, so I do actually. And so the last part, I think we all know that plays a role, and I'm not sure we can do anything about that. But you did bring to mind an interesting initiative that we've just started called the Heart Team Academy. And so I work very closely with Marty Leon, who is the, structural heart, cardiologist at Columbia, and that we were the principal investigators of the partner trial together. And we got approached about 6 months ago by two European surgeons, Thomas Modine of Toulouse, France, and Payman Sardia, a mitral valve surgeon in the Netherlands, in Maastricht. And they had an idea to start an international heart team academy to be able to have best practices and develop a standardized approach of a heart team that could be applicable anywhere in the world. Everybody says they have a heart team now, but oftentimes it's just a checkbox, and it's really not a functional heart team in which we discuss and make decisions about patients together. So they have come up with this idea of starting an international heart team academy. And we are now very engaged with this. We now have a team in Europe and a team in the United States of 8 specialists, 4 cardiologists and 4 surgeons in Europe, and 4 cardiologists and 4 surgeons in the United States that are developing this academy and begin to developing methodology to implement a functioning heart team in different centers around the world. And I think if you have some younger folks that would be interested in this and could get some of your cardiology colleagues engaged, we would love to invite you to participate in this Heart Team Academy. I think it's an opportunity whose time has come. I think we can really make this happen. And I think if this is something that we can promote going forward and develop this to be the standard of care, then I think that a lot of the that issue that you brought up, Rodolfo, hopefully we can address. So I can communicate with everyone afterwards, but if there would be interest in Brazil in this Heart Team Academy, I'd be more than happy to get folks involved.
Fernando, I have
Michael.
a short comment about this.
We are about the time. We are closing the session.
This is very short. This is very short, Fernando. And I'm concerned that the major barrier for implement this kind of ideas are the human being behavior. So this is something that I get very nervous about this because the human being are a barrier, or the human being behavior are a barrier to the team player, to do things together, to all these issues that we have been discussing today.
I totally agree. This is a hard challenge, but I think we want to take it on. And I think it's an extremely important initiative to do, but I couldn't agree more. It's all the biggest obstacle is the human beings involved.
Thank you.
Mike, maybe we should need by now a tutorial for building a heart team, because this is something that it's easy to be done by experienced people. To build a tutorial for the young groups that are starting to work together. I think that this would be a good idea. And of course, we are very much interested in the Heart Team Academy, no question.
For that, Fernando, young people should be invited to be guests of this, this conversation and this meeting of the Academy. I mean,
absolutely,
because this is something that we argue and discuss together here, but they're not aware of that. So they should be guests, sitting up up there, listening to this discussion, making questions, and the question of the young people are very important because they reflect what they have learned.
Okay, well, Mike, thanks a lot for your time. It's more than an hour and a half that we are hearing you and discussing things. It's been a very, very fantastic evening. Thank you very much, Michael. And you can count on your friends from Brazil. We are all your fans. Very good.
Well, thank you very much, Fernando. And it's so great to see all of my friends again, even though it's virtually. And it's been my pleasure to be able to participate in this. And Fernando, I'll be glad to follow up with you regarding this Heart Team Academy and figuring out how we can get involvement from physicians in Brazil. So again, thank you for having me. And I hope to see you all in either Brazil or the United States in the not too distant future.
Okay, thanks a lot. I pass to the President Vanderlei.
Muito obrigado a todos os que participaram debatendo. Muito obrigado ao professor Michael Mack pela brilhante exposição. Esperamos que ele nos brinde com outras apresentações aqui. Tivemos uma boa plateia aqui no Zoom e no YouTube, né? E já anunciar que no dia 5 de maio, né, às 19 horas, nós vamos ter uma aula sobre reflexões sobre o Sistema Único de Saúde pelo professor Jarbas Barbosa, que hoje é o vice-presidente da Organização Pan-Americana de Saúde. Uma aula muito importante, né, para a gente refletir, né, e pensar como manter, né, e fortalecer o Sistema Único de Saúde, que é a maior conquista da nossa geração. Então, muito obrigado a todos e que Deus nos proteja.
Thank you.
Thank you.
Michael, I'll be sending an email to you about the Academy and